And we do have some new names here, so people, I think, who don't know me. So my name is Rhea Markowitz, and I'm from the Georgia Cancer Center, and I'm part of the hub team for our TeleDerm project. And Dr. Patton and I will be serving as co-facilitators of this TeleECHO session. So as usual, we ask that unless you have a bandwidth problem, that everyone put themselves on gallery view so we can see everyone's faces, and especially when we have discussions going on. I want to welcome our teledermatology clinic healthcare providers. That's the other part of the TeleDerm project, and these include the East Georgia Healthcare Centers from Mount Vernon, Soperton, Evans Health and Wellness, Baxley, Metter, Sylvania, Wadley, Swainsboro, and possibly someone from the Albany Area Primary Healthcare Center and the Phoebe Family Medicine Residency Program, and also possibly the MCG Family Medicine Residency Program. If you're not here today, I understand they'll be joining us again probably next month. And then I want to welcome everyone on our TeleDerm team. We've got our dermatologist, Dr. Davis, Dr. Rabinovitz, Dr. Buchanan. There may be some derm residents and medical students as well. Here in the TeleDerm hub, or the TeleECHO, sorry, the TeleECHO hub are Brenda Santiano handling the controls, Mu Sharara handling controls, and myself. So I've already mentioned, please put in the chat your full name, your email address, and what clinic or program that you are associated with. Before we go further, I want to check in with people, especially the new people who may have had problems in obtaining the CME credit. If you still are having problems registering the original registration process, let Brenda know, and she will walk you through it. You can just put it in the chat, and she'll help you with it. Hopefully everyone registered on iEcho. You couldn't have gotten into this meeting, I don't think, unless you had. So hopefully that's a new change for the program, and hopefully that's working smoothly. So now I want to review today's agenda with you. So we've done our introduction. We will have our didactic presentation by Dr. Victoria Madray, who's a resident in the Department of Dermatology here at AU. And then following that, we will have a case presentation by Hanna Myers, who's a third-year medical student here at MCG. Both Victoria and Hanna are part of another dermatology project, which is the Converge project, which is a collaboration with a university in Scotland. So we already have that association. So we'll have those two presentations, we'll have discussion, and a reminder after with our two presenters to turn off your slides as soon as you finish presenting, so we can have a good discussion face to face. Let's see. I think that I can now turn the program over to Dr. Doug Patton, who will continue. Dr. Patton is the Dean of the Southwest Georgia Regional Campus of Medical College of Georgia, and he spent most of his career as a rural physician and then as a wonderful medical educator and administrator. So take it away, Doug.
Thank you, Rhea, and welcome everyone to our first session of 2024. I hope everyone did, in fact, have a nice holiday season, but it's time to get back to work. So today we're going to have a great presentation. And before we do that, we're going to run through very quickly just some of our background slides that we always do. So Project ECHO stands for Extension for Community Healthcare Outcomes, and the tagline is moving knowledge instead of people. The idea is to make this information available to as wide a group as possible and for us all to learn from each other. Next slide, please. So again, this is to improve knowledge about telemedicine, but it's actually teleeducation, and we're going to educate each other by sharing our thoughts and our observations around the presentations that you're going to hear today. The goal is to address the dermatologic health disparities faced by people living in rural areas where access to expert dermatology care may be hard to come by or unaffordable. Next slide, please. So again, these sessions are recorded, as you've heard before. Your participation implies consent to that. And a reminder not to mention any PHI. These are not consultations. These are educational sessions. So we're not to share protected health information on anyone. There's always an opportunity to email us at teledermatology@augusta.edu. Of course, the chat is available throughout the presentation. And thank you for those of you who put your information and signed in the chat. Next slide, please. We do collect data. We collect a lot of data from registration through interactive polls to everything else, including the recordings of these, which are available to us all in archive fashion. Anytime you want to go back and look at a previous one, this helps us to plan for future programs based on your feedback so that we can continue to make these as valuable as possible. Next slide, please. Just again, general reminders about muting your microphone, but leave your camera on if you can. We appreciate that. You can type questions into the chat at any time. We'll review those when the time becomes appropriate. You can raise your electronic hand if there's a need to get our attention. We'll try and call you when there's an appropriate break. And always introduce yourself with your name and where you practice, what your role is there. Gallery view is most helpful, so we can see all faces, particularly during the discussion portions. You can again chat to Brenda or email at TeleDermatology. Next slide, please. So it's my privilege at this point to introduce Dr. Victoria Madray, who is a third-year PGY3 resident with the MCG Dermatology department. And she's going to talk with us today about blistering conditions. I think that's correct. The slide disappeared, so I want to make sure I got it right, Victoria. Thank you so much for joining us today. And I'm going to turn it over to you now. So if we can share those slides, that would be great.
Thank you, Dr. Patton. Let me get that pulled up. Okay. Are you all seeing that screen?
Not yet.
We did get this and made sure it worked, so we should be good.
There
There we go.
we go.
Got it.
Perfect.
Thank you.
Yeah, so just like Dr. Patton talked about, I'm going to be speaking about blistering diseases, disorders. Specifically, I kind of focused on the blistering differential in primary care. And what I meant by that is the blistering disorders that we see a lot of times in our consults or when we're talking to internal medicine or family medicine physicians, which we get consulted for things like that in the hospital all the time. So I wanted to make this applicable. When I'm talking about the blistering disorders, just a review is that, blistering, we kind of describe that as either vesicles or bulla, vesicles being smaller, less than 5 millimeters, and bulla being larger. So I'm going to use those terms during this presentation. And then, as we said, these are not my photos of patients. These are photos that I've gotten from one of our learning resources, Visual DX, just to be clear. So we'll go ahead and get started. And I made it case-based, so hopefully it's interactive for everyone. So this first case, you can imagine is a patient that comes to the hospital maybe for shortness of breath. The workup reveals that they're in heart failure. They've got gross volume overload. While you're examining the patient, you notice that they have these findings on the lower extremity. And you ask the patient, how long have these findings been there? They say, oh, they've been there for months, but recently they're worse. It's itchy. Less painful than itch, mostly itch, no new medications, although you review the medicine list and maybe they're on amlodipine or gabapentin. So everything in the picture is pointing us to the fact that this person has lower extremity edema, and these changes have been going on for quite some time, and the changes are on both of the lower extremities. So this is, one of the differentials that we see all the time is stasis dermatitis. And usually we're trying to decide from a primary care standpoint, they're asking, is this stasis dermatitis or is this cellulitis that needs to be treated? When you see that bular vesicles on the bottom of the bilateral lower legs, we lean more towards stasis dermatitis. So here I said, it can present with eczema-like features, which can include that weeping appearance, vesicles, bulla at times, which you're seeing on that right leg in the screen. And then some changes over the top like erythema and scale. Usually, like I said, this is on the bilateral lower extremities, but it's okay if one extremity is worse than the other extremity. Dr. Davis often talks about, one of the legs being worse in females just because of our anatomy and the changes that we go through. So it's okay if one leg is worse than the other, but if something's on the bilateral lower extremities, it's been going on for quite some time, and you don't have other signs or symptoms, you're leaning more towards stasis dermatitis. And really the treatment of this is fairly straightforward. We can give a strong, high potency topical steroid and then transition to a less potent topical steroid, but really we need to have some compression of the lower legs. And then those medicines that I mentioned, some of the main medicines that we see in clinic that could contribute to lower leg edema is amlodipine, which is a calcium channel blocker, or gabapentin, or pregabalin. We see that a lot in our patient population. So thinking about things, that the patient may be on that you have to ask yourself, is that really necessary? So that's going to be our first case. So here you have case 2. As you can see in the picture, we're looking at some papules that may be urticarial in nature towards the periphery, and then they've got vesicles in the center and a line. And this patient comes to your office. She says this is very itchy. It's on the lower extremity. That's what we're looking at. And she said, she hasn't had any new changes, but she's recently had to stay at a rehabilitation facility after being discharged from the hospital. She doesn't live at home with anyone else. She doesn't have any pets or animals in the home. And she denies gardening or being outdoors. So here, I want to point out, you're looking at eruption in a line on an extremity that's been exposed, and she's been in a facility where she could have been exposed to a bug. So this is bullous arthropod. We see bullous arthropod quite frequently in our clinic as a referral. It's very common in children. That's a normal response for children to have like a bullous reaction to bug bites. You can also see it in adults that have hematologic malignancies or HIV. Here I'm mentioning that it's in a straight line because one of the common bugs that we see, bed bugs, they kind of take bites in a line. We call it like breakfast, lunch, and dinner. So you're seeing them come back for a little bit more each time. So that line there is classic for that. Other bugs that we see, chiggers, they like to be right above the sock line. We have those here. Fleas on lower extremity or exposed skin. Often patients will tell you if they've seen fleas or if they have animals in the home. Not to forget, squirrels carry fleas. So a lot of times whenever you have a lot of squirrels in the backyard, things like that, you'll have fleas. And then scabies, always looking in the web spaces. Usually in adult patients, scabies will not go above the neck, but it can in children. So that's one thing we like to ask about. So you're looking for multiple vesicles with a classic history, and also, asking yourself in the adult population, do they have something else going on that would make them have this bullous reaction? Most of the time when this patient comes into the clinic, we give them a strong topical steroid or a medium potency steroid, tell them to go ahead and treat that spot they've got twice a day for 5 to 7 days, and then they have it on hand if they're to have, this eruption again. And then you can also wash your clothing in pesticide that can prevent like kids from being bitten when they're outdoors. That's another little trick that we talk to patients about. So our third case, this patient presents to your office after developing blisters on his arm. They're pretty impressive. He says he scraped his arm at work. He had put a Band-Aid over the area, went on with his day, thought nothing was wrong, and then 2 days later started having these blisters arise. Now he's worried that the scrape he got was infected. It's very itchy, and he doesn't have blisters anywhere else. And when you look closely, you kind of notice, I've got this on this screen, you notice that the blisters are really confined mostly to the area where the bandage was applied. So, looking for these like squared off borders or irregular borders is a big clue whenever you're seeing blisters that are just in one focal area. And so you make a diagnosis of allergic or irritant contact dermatitis. Allergic, meaning that you've got an allergy to something that is in the material you're exposed to. Irritant being irritant to the skin. Sometimes patients will have irritant dermatitis of the hands if they're washing dishes, if they're a dishwasher or something like that. Allergic contact dermatitis, a lot of the time we're looking for these classic locations. Specifically the neck if they're wearing costume jewelry, the wrist if they have, a watch that has rubber in it, the waist if you have someone that's got belt buckles or the fastening of the belt or the pant over the umbilicus. That's where you're looking for like classic locations, or like I said, if it's got a well demarcated shape. So really this comes down to knowing what those classic locations are and to asking a really good history, specifically what their daily routine is, what recent exposures they've had. One thing we have patients say all the time, for instance, we talk about triple antibiotic and the fact that you can have an allergic contact dermatitis to triple antibiotic after you put it on a wound, and patients will say, well, I've used Neosporin my entire life. I've never had any type of reaction before. And, we like to always say it's not the new friend, it's the old friend that eventually kind of comes into play and gets you with this. So it's not unreasonable for it to have been something that they've been exposed to before and not had any trouble. So really just asking a good history. And again, we treat this with a topical steroid. The strength really depends on the site and how severe it is, anywhere from medium to high potency. Sometimes you can get a systemic reaction if you've inhaled it. If you've inhaled, like if poison ivy or poison oak is being burned and you've inhaled that, you can get sort of a systemic eruption. And that's really one of the only times that, and if you have involvement around the eyes, that we've written oral steroids for any of this. Usually we just stick straight to topical steroids. So this is our fourth case. This is a patient with uncontrolled diabetes for several years that's admitted to the ICU for diabetic ketoacidosis. And on the day after admission, you notice a large bulla on the lower extremity. The patient states that these have happened in the past. They've resolved over 2 to 6 weeks. They kind of come and go. He's not really worried about it. And the fluid of the bulla is clear, no associated symptoms. So again, you're noticing patient has diabetes, bulla are very large with serous to clear fluid, and this has happened before and resolved. So with that in mind, you're making the diagnosis of diabetic bulla. So diabetic bulla are typically described as tense, non-inflammatory bulla. Usually they have clear or hemorrhagic bulla, hemorrhagic fluid, and they're large usually. And usually located more on acral sites. The treatment of this really is just to manage their diabetes, manage their glucose levels. We do recommend wound care to prevent infection because these are diabetic patients where a lower extremity wound would be not ideal. So you can use a barrier cream if it were to de-roof, and if it does de-roof and it looks infected, have a low threshold to swab and make sure that there is no infection once you kind of lose that nature's Band-Aid. One thing that may be in the differential for this diabetic bulla in the situation that I gave you is what next case I was talking about. So this is a patient that comes to the ED in sickle cell crisis. They're started on IV fluids and pain meds. The following day, she has a large bulla on the lower extremity that occurs. And when you ask, what did you do overnight? Did you hit your leg? Because it looks like here one has been deroofed. She said, no, I didn't do anything. I just sat in the chair. I watched TV, just, was starting to feel better. So you're saying, okay, you sat in the chair, your legs were dependent. Here the bulla are more full of clear fluid, and like I said, one is deroofed. So in this instance, we're making the diagnosis of edema bulla or hydrostatic blisters. So these are also tense bulla with a thin roof that rupture easily. So very similar to the diabetic bulla, but just a little bit of a different history, right? This person just got IV fluids in a sickle cell crisis. This is almost to a T at one of the consults that I had earlier on this year. They have a history of having that acute edema. This can also occur in patients that have chronic lymphedema. And it's the management is essentially the same as far as symptomatic management, with the expectation that this is going to resolve as the edema resolves. So this case here, this is an adolescent patient that presents with new painful blisters on the bottom of both feet. He denies any history of blistering in the past, no family history of blistering. You think, well, this is odd. It's on bilateral feet. Did you do anything new recently? He says, yes, I just joined the marching band at school. Other than that, I haven't done anything new. So that's a pretty easy diagnosis to make of a friction or a trauma blister. So here you can have large bulla either on the palms or the soles, depending on what activity the patient's doing. And it's just related to friction trauma, kind of rubbing of those layers of skin over the top of each other. They can be clear or they can be full of blood, so they can have like a purple or a red color to them, and it's just symptomatic management as well. So you're just asking, people that you think about this, like the marching band or someone that just recently joined the army, someone that's kind of had a lot of activity lately than they're not used to. So I didn't realize we were going to take questions at the end. I'm happy to do it that way. Those were kind of like my first group that are common that we see, that is really mostly benign etiologies, very simple management. And that was kind of the first group that I had. The next group I want to run into are this group of kind of infectious, bacterial and viral diagnoses that can have sort of a vesicular look. So this is a case, a high school football coach that comes to your office. He's got painful crusted spots on the face. You can see they've got sort of that honey colored look to them. And he says, this happened all of a sudden. The only thing I know is that one of my players also had similar findings last week. The coach is immunocompromised on chronic steroids for inflammatory bowel disease. And he says, when I was younger, I used to get a lot of staph abscesses. So this is again, pretty straightforward bullous impetigo. So impetigo, we know, has that honey colored crust look to it. This person is telling you they have a history of staph. And then sometimes you can get these changes sort of here where this is an erosion in the center, but you can see where he's got a vesicle or kind of bulla on the nose. And, some of these may have been similar before you had that secondary change. This is due to staph or beta hemolytic strep. It spreads very easily with contact. That's why that history is telling you like he was around children. It's very common in kids. The management of this, you can culture this to see if it's MSSA or MRSA. You want to have good hygiene. Like I said, it's very contagious, so you don't want to share towels or washing in the same space as other people. And then avoiding contact sports or sharing of hygiene products. A lot of times we'll do mupirocin in the nose and in the folds to decolonize patients that have like recurrent staph infections, or you can give oral antibiotics like doxycycline would cover the staph. This is case 8. I think most of us can realize that this looks like shingles, and that's exactly what we're describing here in this case. Extremely painful rash on the abdomen for 2 days. 5 days ago, he had pain in the area before the eruption. He's not received any vaccinations, no other skin complaints. So here, shingles due to reactivation of varicella. The big thing is just to recognize it's in that dermatome. It's kind of running together. I thought this was a nice picture in Skin of Color where you can see that subtle erythema in the background. And then some of these are starting to crust over. Once the entire lesion has crusted over, the person is no longer symptomatic. That's the big key. Until that, they are contagious. You want to make sure they're not around anyone that's immunocompromised or pregnant. The big thing that you worry about is post-herpetic neuralgia. That's the teaching point here, that a lot of times we're taught you need to start the Valtrex in the first 3 days, but really you can have clinical impact as long as you're starting within the first week. So something to keep in mind if someone comes to your office and it's day 4 or 5, just go ahead and give the Valtrex and hope that you can help that patient in the long run. Case 9. 30-year-old male presents to the primary care physician with complaint of painful blisters on his bottom. So if we're looking at this picture, we can see you have these grouped pustules/vesicles on the bottom, and he says these have recurred. These are some that maybe have a little bit of crusting and erosion there. And he says he used to be a wrestler in high school. He's had these come and go, never had them treated, but now he has a new partner, and they're wanting to make sure they're not contagious. So you make the diagnosis of herpes simplex. You can have gladiatorius specifically whenever you have this in the wrestling population. So that is part of that history. Usually if this is the primary disease, it is going to have worse symptoms and more ulceration than if this is recurrent disease. Recurrent disease, you get more of the group vesicles on an erythematous base. Typically we talked about punched out erosions or punched out ulcerations in herpes, and that occurs oftentimes if you have areas of friction like in the folds. If you're unsure, you can always do a PCR of the base. Although if this has been there for quite some time, we recently had a consult that it had been there for over 10 or 15 days and the PCR was negative, although it was clinically consistent with HSV. So depending on the timeline, the PCR may be negative. And then treatment, supportive care, you can give treatment doses of Valtrex. And then if they've had more than 6 episodes of HSV in the year, you can give a daily antiviral dose, like once the treatment dose has run its course. Usually the treatment dose is for 7 to 10 days, and then you can switch to say 500 milligrams a day of Valtrex for a prophylaxis. And then case 10, I believe this is my last case, a middle-aged male that presents to your clinic with an itchy, painful rash for 3 days. He reports visiting his grandchildren 1 week ago, and after he returned home, he had a low-grade fever and body aches for 3 days prior to rash, no other skin complaints. So I like to put this here because we think of varicella or chickenpox in the pediatric population, but can happen in adult population. So you're here, you're realizing that they've been around children. And when you look at the lesions, one of the things to point out here is that they're all at different stages of healing. That's classic for varicella. And then this is at, I think I've got it described here, dewdrop on a rose petal. So you see you've got sort of this pustular vesicle that's sort of sitting on that erythematous base, just sitting on top of it. That's the description for varicella. Kids, a lot of times, some of them can feel not well, but most of the time, you know, they're okay. But adults typically have that prodrome. And again, you can just do symptomatic treatment. Consider Valtrex to decrease severity of the outbreak if it's administered early. So that is a section that I had sort of on bacterial and viral eruptions. Lastly, because we are dermatologists and we do see skin conditions that do require specialty care, I didn't want to focus mainly on those, but I do want to talk about some of the blistering disorders that really are seen in specialty care and should be seen in specialty care and followed closely by your dermatologist that you have in your area or that you have access to. And maybe some high yield points for those so that they're easy to recognize. When should you call the dermatologist and call them quickly? So I'm going to go through these quickly and kind of flip back and forth. I have the pictures here on the next slide. So we'll talk quickly about each one of those and then I'll finish up. This first category is bullous drug. Specifically within that, you have fixed drug and then SJST, and that's the condition that no dermatologist wants to get a call for and that we all worry about. So for fixed drugs, specifically what you're looking for are that these spots heal very dark, and every time they get exposure to the drug, it comes back in the same location. So they'll say, I had this ibuprofen or NSAID last time I got the spots and then they healed really dark and now they're in the same spot again. And so you can see here there, this is again skin of color. You can see that subtle erythema and then that kind of dusky dark color occurring in the same spot. And then for SJS-TEN, the real thing to think about with that is that you should have mucosal involvement, erosion or change of the lips, or the eyes, or the urethra in men and women. And then when you're looking at the skin, you're looking for this full thickness skin sloughing. So you're seeing here that you've lost the entire epidermis. And if you were to kind of shear that skin, that entire epidermis would kind of shear off. That's a positive Nikolsky sign. So that's the two bullish drugs. Dermatitis herpetiformis, we shorten it to DH. That is associated with your celiac disease. You get excoriated vesicles on extensor surfaces. The big thing here is that you should change the diet in order to decrease your risk of lymphoma. And a lot of times these vesicles are very easily ruptured. So by the time you see them in clinic, they're deroofed. You just have these kind of excoriated or eroded papules. And the extensor surfaces that we're talking about, I'm sorry, I'm here. The extensor surfaces that we're talking about are the elbows, the knees, the buttock. That's the main areas. And I was looking at the wrong screen. This is what I was talking about, that full thickness sloughing in SJS. The next disorder I wanted to highlight was bullous pemphigoid. Bullous pemphigoid is the tense blisters that you get. They can be very urticarial and they can, they're very tense and they can be large. So big picture, see how these are larger. They're on that pink urticarial base and these patients are itchy. So if you were to press down on that blister, it would be hard to rupture versus pemphigus vulgaris here. These are much more friable blisters. It should involve the mucosal sites, and they're much easier to rupture, which is why you're left over with some crust. I included Haley because that's our big pathological differential from pemphigus vulgaris. And the big thing here is that you just have eroded plaques, usually in flexural surfaces. So under the breast, in the creases of the arms, under the pannus. That's where we're looking for Haley. These last two, LABD, this is linear IgA bullous dermatitis. So this is seen in kids and adults, and I just like to throw it out there because it's got this nice morphology. We call it like a crown of jewels, where you've got these vesicles that sort of outline the outside of the lesion. So if you're seeing that, you know, we can get them in clinic, get them on a medicine to treat that. And then lastly, EBA. That is epidermolysis bullosa acquisita, a blistering disease that heals with scarring and milia. So very similar in appearance to porphyria, common on the backs of the hands. And here we're talking about healing with milia. Those are those little white dots. Again, if you see this, you know, any of these really, this is the time to call your local dermatologist and phone a friend and let us kind of get involved and help. But just kind of wanted to give a clinical picture of what to expect and what to be looking for. So with that, I think I will finish and take any questions. Let me stop sharing my screen.
There you go. Thank you very much, Dr. Madray. That's wonderful. It's certainly very comprehensive, and we've all seen these sorts of things. I'm wondering if anyone from East Georgia Health Center might have a question or something that they could share of an interesting lesion that they've seen and dealt with. You know, put you on the spot, my East Georgia friends. So I will say that I had never, ever in my life heard of the bed bugs in a line description before, where there's breakfast, lunch, and dinner. So I learned something brand new today that I've never seen before. So see any questions? I don't see any raised. Oh, we do have a raised hand. Dr. Sheldon, there you are. Thank you. You're muted, sir.
There I go.
There
All
you
right.
go.
There was a. Oh, can you put your volume down? We're watching this in conjunction, and so there's an echo.
That's why we call them Project Echo, sir.
Oh, it's brilliant. So that was a really good presentation, a lot of learning there and a lot of junk that we in PC primary care have to deal with that some of us feel more or less comfortable with. I'm probably a little bit on the less comfortable, so I soak up all that information, and thank you so much. I did have a case that looked similar to the stasis dermatitis, actually, this probably right before I saw you, actually. In fact, she kept me kept wanting another thing. I almost missed the presentation. I just said, wait a second, I have to listen to what Vicky's gonna say so that I can figure this all out. Okay. But she did have the lower extremity edema, and she was on Imdur and gabapentin. And she was elderly, so there was a definite element of venous stasis. She put on the stocking hose though, and it seemed to maybe cause a little bit of a rash as well, sort of cauliflower looking, and on but both legs, and somewhat itching, but not very pruritic. I chose to do, and I don't do this a lot, but I did a 4 or 5 day course of Lasix, 20 milligrams. And I know that's not usually the best for, in principle, you want something that's cardiac if it's Lasix, but I have found that occasionally you do a 4 or 5 day course of Lasix, that it will clear up the edema. And then it looked like there was a superimposed infection. So I gave her a little bit of doxycycline to go with that as well. I didn't do the topical steroid because she didn't complain of a lot of itching. But I'm going to have her come back in about 5 days, 6 days, and just see what the response was. But that was my interesting thing for today. And but I'd be happy to get your input.
Thanks, Dr. Sheldon. I think it's important that you address the notion of making sure that you address the itching, because even in my own career 100 years ago when I was still active, would see people who come in with secondary infections from scratching, and things like that. So being able to help with that, I'm sure, was important. Dr. Madray, you have anything to add to that?
I would just say that, I can see where the Lasix would help in the short course, but we want to make sure that you've got something that's going to help with the lower extremity edema over the long course. If you think she's having some type of reaction to the stocking or the compression stocking that she's wearing, just making sure that, does she have a history of atopic dermatitis? Is she washing those stockings in anything that's got a lot of scent or smell or dryer sheets, anything that's causing the stocking to be irritating? Because the stocking itself really shouldn't be all that irritating, especially if you're getting a white non-colored compression sock, which you can get over the counter. Just making sure that something in the long run is going to help with the edema, because it's likely that that's more chronic than acute. Yeah, that would be my concern is that if you think there's something that's in the stocking that's causing itch or irritation, asking those questions to make sure that she's doing the best she can to make sure that she can wear those stockings.
It's interesting because the gabapentin was recently increased, and as she said, it helps with her pain, but it may be causing the underlying swelling, lower extremity edema that wasn't there before.
Yeah.
And I like the piece about gravity. We just underestimate the degree that gravity makes our lives better and more miserable at the same time. And probably encouraging, maybe cut back on the gabapentin and encourage her to raise her legs more might be a huge benefit.
Yeah, gravity can be your friend as well as your enemy.
Yeah,
all right, we'll need to move on because we have another presentation. So I'm going to cut this one off. We can come back if we have a little time, but it's my pleasure now to introduce Hanna Myers, who is a third-year med student at MCG, and she has a case presentation to share with us. Hanna, are you where you can do that?
Hey, yes. How are you, Dr. Ben?
Good to see you.
Thanks for the introduction. Can everyone see my screen?
We can.
Yes.
There you
Alrighty. Well, we can go ahead and get started. So we're doing a little bit of a different case presentation today. We're actually going to focus on 5 benign facial lesions that are commonly presenting to clinics and how to recognize them both clinically and dermoscopically. The 5 lesions we're going to focus on today are angioma, intradermal nevus, sebaceous hyperplasia, seborrheic keratosis, and venous flake. And the nice thing about all these lesions is when they present on the face, we see the face of almost every patient that comes into clinic. So if you see it when they are arriving for the appointment or something comes up on physical exam, you're able to identify them with either the clinical presentation or the backup of dermoscopy and reassure the patient that, these don't need to go any further. They're completely benign. Nothing needs to be done. The overlying goal of this presentation is to help with the clinical recognition portion and then using dermoscopy to actually confirm that diagnosis. Nope, there we go. The first lesion we're going to talk about today is angioma. So this is a very common lesion. It occurs more as we get older. So over 75% of adults over 75 have angiomas. However, it can present in younger individuals as well. Around 5 to 7% of adolescents will have an angioma as well. So they can really be any age and present with an angioma. On clinical presentation, these will be red, smooth papules. They'll be well circumscribed and very discreet, but they can be traumatized. So if they get scratched or if they are itchy or something of that nature, they can look a little bit different, but those dermoscopy features should still be present on exam if you want to confirm the clinical diagnosis. Under dermoscopy, we're going to see things like red and purple lacuna, so those red patches, and then the white septa, which are the lighter patches that are going through them in this cartoon representation right here. One important note about angiomas is on darker skin, they can appear more violaceous or purple rather than more erythematous or red that we see in lighter skin tones. On the left here is a clinical photo of an angioma. Again, it's going to be that well circumscribed red papule. This photo is a photo of a younger patient, helping represent that any age range really can have angiomas. And then these two dermoscopy photos help illustrate those dermoscopic findings as well, the red lacuna and then the white septa going through those lesions. With angioma, if you use your dermatoscope, you can press down on it and the lesion can blanch a little bit. They are vascular lesions. However, they don't have to completely blanch, but it can help confirm that diagnosis. The next lesion we're going to talk about is intradermal nevus. So similar to angiomas, these are going to present as well circumscribed papules. However, the coloring is going to be a little bit different. They're going to be tan to brown in color rather than that true red of an angioma. These are more common in the third decade of life. So again, a little bit more in our older patients. And under dermoscopy, you'll see certain characteristics that will help confirm the diagnosis. So those brown globules over here, the comma-shaped vessels, and then you'll even have little halos around the vessels that are kind of golden brown. All of those features can help confirm that it is an intradermal nevus. Here are two pictures of clinical intradermal nevi. The one on the left is maybe more of a light brown color, and then the one on the right on the darker skin tone patient can even be black. So that's something that's important to recognize. Even darker colors are not worrisome here. Under dermoscopy, you're going to see some different features that we were talking about earlier. So those curved vessels on the side over here, and then those brown globules, and those are all reassuring that this is an intradermal nevus. And then on the right, I wanted to point out, this one looks a little, Dr. Markowitz, when I was flipping through my presentation, she said it looked a little gross, but it just has a little bit of a golden crest on it, and that is just secondary to build up over time. The next lesion we're going to talk about that's a benign finding that can be on the face is sebaceous hyperplasia. So these will be a little yellow, pink papule. They'll have a central umbilication, like a central dip in the middle of the lesion, and they can appear almost spongy or soft on the clinical appearance. Dermoscopy-wise, you'll see some popcorn lobules is what they're called. They're yellow to white in the middle of the lesion, and then you'll see these crown vessels. And when we say crown vessels, essentially what we mean is just a periphery of vessels that don't cross the midline of the lesion. And those are all pathognomonic for sebaceous hyperplasia. Sebaceous hyperplasias are more common and lighter and oilier skin, and they're also more common in groups. So a couple of them will often pop up all at one time. Here are some clinical photos of sebaceous hyperplasia, and again reflect that pink to yellow soft papule. You'll see in this photo there are a couple of them all grouped together. So like I said, you can find a little conglomerate of them. Under dermoscopy, you're going to see these reassuring features, the popcorn-like lobules and the crown vessels. So all of these vessels, they don't cross midline, they kind of stay right on the periphery of that lesion. Seborrheic keratosis is the next benign lesion we're going to talk about today, and these have a lot of variety. They can be a variety of different sizes. They can be a variety of different colors, brown, black, yellow, white. They can all appear in seborrheic keratosis, and that's not necessarily a worrying feature. These will pretty much all have a stuck-on papule appearance. Some of them are more clear than others, and they'll have a well-circumscribed border clinically that all supports the diagnosis of seborrheic keratosis. Under dermoscopy, you'll see some different identifiers that can help as well. These milia-like cysts, these little white dots, comedo-like openings, so the little dark dots, some wavy patterns like fingerprinting or fissures and ridges, and then even some halos around the vessels as well, and all of those help support seborrheic keratoses. These also increase with age, so the more birthdays we have, the more we get, and they are more common in lighter skin tones as well. So something to look out for in your lighter skin tone patients. Both of these patients here are clinical presentations of seborrheic keratoses, and we do have a couple more photos of seborrheic keratoses because there is such a variety of presentation, but both of these are those dark brown, even black papules. The one on the right really illustrates that stuck-on appearance. And then under dermoscopy, you're going to see those features again that are reassuring. It is a seborrheic keratosis, the comedo-like openings over here, the ridges, and then these fissures. Here's another example of a seborrheic keratosis. This one looks a little bit more irregular, so I thought it was interesting. One thing we always look for is that irregular border, the multi-tone, but with seborrheic keratoses, that's completely fine and nothing that needs to be investigated further. On dermoscopy, when we're looking for confirmation, again, we'll see those ridges and fissures. The last picture of a seborrheic keratosis, again, is going to be that little brown papule, multicolor, kind of irregular, but then under dermoscopy, you'll see the reassuring features of milia-like cysts and comedo-like openings. The last benign lesion we're going to talk about is a venous lake. It is also a vascular lesion. It's a superficial dilation of veins, and it really appears as a purple, blue, papule, or soft nodule. It's compressible, so when you press on it, either with the dermatoscope or with your finger, it will go down. It will not necessarily blanch, even though it is a vascular lesion, so no need to worry if it doesn't blanch. And it is most common on sun-exposed areas like the ears and the lips. Under dermoscopy, you're going to find similar findings to what we found with that angioma, which is another vascular lesion. The white lines and the purple and blue homogeneous areas that are present on this picture here. The black arrows are pointing to the homogeneous areas, and these white arrows show us those lines between the areas. Then here are two clinical photos of venous lakes, again on the ear, very common because they are sun exposed, and they're that blue-purple kind of compressible lesion. Under dermoscopy, we're going to see those homogeneous areas and the white lines that support our diagnosis of venous lake. These are also harder to see in darker skin types because of the coloring, so something to be aware of. In your lighter patients, they may be more present, but they're also present in your darker skin patients, just sometimes harder to see. This is just a great representation of a variety of benign lesions and all the different patterns that we can see under dermoscopy. So some of those we talked about today. We have the intradermal nevus over here, the sebaceous hyperplasia down here, and of all of these different presentations of the seborrheic keratosis. So it's just a good wrap up of different benign lesions. And then a quick review of all the dermoscopic features we talked about today. I know there's a lot and they can be hard to remember, but the angioma and the venous lake are kind of similar. They're both going to have those red, purple lacuna and the white septa in between. The seborrheic keratosis has the most variety. It can have milia-like cysts, comedo-like openings, the wavy lines that are fissures and ridges, and even halos around their vessels. Sebaceous hyperplasia, we're going to see those crown periphery vessels with lobules in the middle that are popcorn-like. And then finally with intradermal nevus, you'll see brown globules, comma-shaped vessels, and a brown halo. So I wanted to do, I don't know how this will work with the presentation being up, but I wanted to see if anyone wanted to describe this lesion and we could talk about it as a group. Any takers?
we're running a little tight on time. I'm gonna ask you to go ahead and keep up with it, Hannah.
Yeah, sure, absolutely.
Sorry about that.
No, thank you for keeping me on time. This lesion on the left over here is kind of a red-brown papule. And when we look at it under dermoscopy, we're going to find the features that we talked about earlier. We'll see those brown globules and those curved vessels that are really classic for an intradermal nevus. And that is all I have for everyone today. I wanted to thank y'all for your time and thank Dr. Buchanan for the opportunity to present. But does anyone have any questions? And I'll get out.
Thank you, Hannah. That's a great presentation and a great reminder to us that we all have access to these dermatoscopes, the mole scopes, and we should be taking advantage of those to upload our images to the experts so that we can continue to learn even in between the sessions. So thanks for that. I don't see any hands up or questions related to that specifically in the chat. We are going to wrap up real quick, but I don't want to ignore Mackenzie's question or Kyle's question. So Kyle asked briefly, do we have a problem with use of compression stockings if venous stasis is made basically on a clinical findings alone when we can't get vascular studies? I mean, one of our dermatology experts who deals with these, maybe you might have a thought on that, Dr. Davis, or you want to punt?
Well, we see so much lower leg edema. Many people don't realize they have it. I'll take my finger and push and, you get this big indentation. They have no idea that they even have swelling. I have a lot of patients who'll say, well, I have bird legs. So even bird legs can have swelling. So we really don't hesitate to recommend support stockings. And I think it's important to realize you don't have to use 40 millimeter mercury pressure support stockings. People won't do it. They'll sit in the drawer and they cost a lot of money. So, be reasonable. Start with something, 10, 12, 15 and work up. I think it's important to know that you can put layers of support stockings on. So if they tolerate that 12 or 15, put a second one over it. Use it like a sleeve. And so, unless they have real bad arterial disease, you're not going to hurt anyone with putting support stockings on. They need to put them on first thing in the morning before they get up and stumble into the kitchen and get their coffee and their breakfast, because then they won't go on very smoothly. So, there are a lot of tricks to that, but we don't hesitate. We preach the same sermon all week long about support stockings. It's one of our favorite tools. And we do try to get people, going back to gabapentin and amlodipine and all these drugs, try to get people to take the least amount of medicine that'll do the trick, especially when it comes to the neuropathy medicines. So often I ask patients, does it help? And they'll say, I don't think so. And well, if it's not helping, then don't take it or lower the dose. So, but it's like a tug of war, and we have a hard time winning if there are too many drugs that cause leg swelling.
Great insight and great practical advice. And of course, I think, the thing that we worry about is putting on compression garments if there's arterial insufficiency, but usually you can determine that based on clinical evaluation as well. So that's great. And by the way, Tractor Supply tends to have a pretty decent supply of compression socks, thigh highs, for usually $15 or less. So you just got to sometimes find them in unusual places. All right, we got one more that I want to make sure we address, and that's from Mackenzie Maloney. It's any tips for sterilizing sporting equipment for athletes with bullous impetigo? We'll leave it to any of our experts to jump on that one real quick before we turn it back over to Rhea.
No, that's a good question. I mean, we recommend chlorhexidine, obviously, for patients who have repeated infections. I guess you could use that on sporting equipment as well. We like dilute bleach, which might not be good for some equipment, but maybe for the right equipment, it might be fine too. Those are the two things that we tend to use the most.
Yeah, I was gonna say the same thing. And just making sure that I couldn't think of a way that would get near the eye, but just remembering that chlorhexidine shouldn't be used on the eye or on equipment that's gonna go directly, like if they have glasses or something, you just maybe would be careful, but I'm sure like a day later it would be fine. You just don't want them to be washing around their face with the chlorhexidine if they buy it to sterilize their equipment. Just recommended that they keep it away from the eyes and the ears.
Great tips, great advice, great presentations. Thank you, Dr. Madray. Thank you, Hannah. We appreciate that. And I'm going to turn it back over to Rhea so we can wrap this up.
Okay. Thanks so much, Dr. Madray. Yeah, that was, I think it was incredible. I think it's probably one of the most, the presentation, probably one of the most useful ones for our PCPs in the rural areas. Cause, you know, I mean, I'm thinking in terms of, you know, I see things on myself and all. So thank you for that. And Hannah, thank you for great presentation. So next, let's see, you put up the, Brenda, have you put up the CME code? Or that'll be in the chat. So don't forget to go for your CME. Our next session will be February 5th. The didactic presentation will be cutaneous signs of internal disease, given by one of our residents, Dr. Joel Byrne. And the case presentation will be by Rashi Agrawal, one of our medical students who's attended a number of these sessions. And she's also been volunteering with the TeleDerm project, going to health fairs with Brenda. So reminder to our TeleDerm clinics to keep sending in consults to Dr. Buchanan using your mole scopes. And thank you everyone for being here. We had great attendance today, and stay warm. Around here, we're supposed to have bad weather tomorrow with a lot of heavy winds, which is nothing like the 10 inches of snow my sister up in Boston got. But just be safe and stay warm and be well, everyone. So all of our guests can sign off now, and I ask our TeleDerm Hub people to stay on for just a couple minutes. So if you would. And Doug, what did you say you could get the compression stockings for in where? In unusual places?
You can get them at Tractor Supply, and they're usually Copper Fit is the brand they sell. And so they're pretty sturdy and very comfortable and easy to get on.
Okay, I've bought mine at Kohl's, but but Tractor Supply.